Okay, welcome back, everybody. If I could just ask the chair people of the two breakout sessions to just, if they could just take about 5 minutes each and talk about what was discussed, what were the issues, and what they think the future might hold, that would be great. Mark Petrie, would you do us the honor of going first?
Yeah, sure. Thanks, John. So we had a very stimulating, very thought-provoking session. To be honest, I'm taken aback by how my personal opinion has changed over the course of the last 2 hours. I think cardiologists come to these meetings with a preconceived idea that what we do is the way that things should be done, but certainly not. And our conversation evolved to what I think might be a pretty good answer to adjudication strategies, and what we came to a reasonable consensus. I think maybe it was universal actually, that we might be able to establish a system where if you have a cancer hospital and you have a cancer trial happening and you have a cardiologist on site, that might be a very valid way of classifying events well. And most of us involved in cardiology trials are very aware that investigators who are knowledgeable are quite good at spotting what the cardiovascular condition is. If, on the other hand, you work in a cancer hospital and you don't have any cardiovascular clinicians, maybe then there should be some external availability of people who are able to classify cardiovascular events well. The exact mechanism of doing that, we didn't agree entirely. There were lots of other things we talked about. We talked about looking at or differentiating between late-stage cancers and early-stage cancers. And there's a feeling that maybe or possibly in late-stage cancers, cardiovascular event adjudication or capture may be less important. I'm not sure there was a universal agreement about that, but certainly in early stage cancers, I think we did feel there was reasons for looking in detail at the cardiovascular risk, but not just in the short term, but short, medium, and long term. So those were two really, really fundamental, profound things we talked about. We did talk about other things such as baseline cardiovascular assessment and how that should be approached, and whether there should be standardized baseline cardiovascular assessment, whether that should be capture of cardiovascular conditions, cardiovascular risk factors. And we had a relatively long discussion about the use of biomarkers in cancer trials, so cardiovascular biomarkers like NT-proBNP and troponin. I think that was the biggest disagreement. I think we've had some differences of opinion with regards to biomarkers, but I think most of us as cardiovascular clinicians are used to using these biomarkers and not overreacting to cardiovascular biomarkers being abnormal. And we touched briefly upon imaging as well, cardiovascular imaging, but of course that would vary between the different trials. I think one of the overarching things which we keep coming back to is that we don't want to hold up the development of new cancer therapies. We want to really work together with oncologists and companies and hopefully regulators to come to some sensible agreement, which is not overly expensive, doesn't stop therapy unnecessarily. But I think most of us involved think we wouldn't stop therapy unnecessarily, we would carry on therapy. So I think we really have a feeling that there's a great deal of opportunity for collaboration between oncologists, cardiologists, industry, and hopefully if regulators get enthused by this, can see the opportunities to clarify the event capture, that would be fantastic. So I think, even in the chat, we've been hearing from CTC people that I think there's probably is room for agreement. But Jim, obviously we've worked together a lot before, and I'm sure I've missed a couple of large issues. So do you want to just to add anything to what my summary?
Yeah, absolutely. We had really an exceptionally good discussion, and what I would say very quickly, just as a disclaimer, as one of the card-carrying biomarker people, folks, I was actually one of the people who felt that biomarkers are overused, actually, because of the lack of understanding about how to interpret them. It creates more angst, and so establishing, clear guidelines with respect to when to measure, how to interpret, is critically important, because I think we're trying to apply the standards for myocardial infarction and heart failure to a group of patients who have a very different physiology. In a global sense, one of the most important aspects that I think I took away from this, number one, is the general consensus. I think that people understand we're not trying to slow things down. We're just trying to be able to prepare for the natural life cycle of a drug that may make it to clinical use. So for a patient that's being treated with a non-curative intent, clearly the goal here is to prolong life as much as possible. However, in the modern era, more and more we're shifting towards a curative or semi-curative type of picture with longer term follow-up and indication drift after a drug has been available for a while, where patients treated with other types of malignancies for longer periods of time might occur. And so understanding and equipping clinicians with the knowledge of what to expect, I think, is critically important. And so that was, I think, a really clear message.
Great. Thanks, Jim and Mark. Mark and Ninian, for the other breakout session, I'm wondering if you'd share with us your thinking.
Yeah, I'll make a few comments and then I'll hand off to Ninian. We had a fantastic conversation, very engaged, a lot of common themes, and just in the interest of time, I won't overlap with all of them, but our three main areas were in terms of baseline characterization, event ascertainment, and then categorization. In terms of baseline characterization, a lot of overlap with what Jim and Mark Pitru said. There was interest in better characterization. I think there was interest in biomarkers, but the same reservations around, creating confusion at the time of inclusion. And if it's elevated, do you need to do a big workup? And will that then make it harder to recruit, or maybe even not make that trial available for patients? And some of the folks in the chat, came up with, I think, Brian Rennie and Anna Barak about, and Tom Nealon about just banking the blood. And so that it's not, the results aren't there to be an inclusion exclusion, they're just there to inform clinicians after the study of what were the baseline levels and what were the changes. So I think that was a good discussion, but I think there was a general consensus around getting more information would be helpful if we do it in a clear way. Resourcing, of course, had to be something that needs to be worked out. The second part for ascertainment was the same thing that Jim, you just raised. First of all, the comment was made, there's no such thing as a real phase one in a lot of these trials. I mean, they're in humans, patients are very sick, and you have to balance the ascertainment of events with how, the population, how long they're going to survive, and the mechanism of the drug. And so I think there was sort of a notion towards a tailored approach there. And then finally, for categorization, and I just want to really thank Dr. Chen for just really being very open about talking about CTCAE and engaging, and I think also helping to frame CTCAE as a grading, not as a diagnostic criteria, and to differentiate. While there are definitions, that diagnosis is different, and I think that's something the other group touched on. But I think there was a call for a collaborative effort to try to work with CTCAE on maybe terms and definitions and grading to come up with some consensus. Ninian, what did I leave out?
I don't think you left much out, Mark. I really enjoyed the conversation, and I think the common themes were that delta and good baseline characterization is good, and the most important thing, and irrespective of the stage of cancer, because those signals are perhaps not so relevant for patients with no option for their cancer treatment, but for patients in later phase trials and in the real world who are perhaps going to be cured, then these are really important things to understand and how to minimize the toxicity, as we were discussing at the beginning. There was a clear steer towards mechanistically targeted follow-up rather than a blanket approach. And really, I think the most positive thing is trying to move forward with CTCAE and ideally set up some better collaboration based on the ICOS document with the harmonized definitions, which will be out fairly soon. So no, I was encouraged. I think there were some pretty clear themes. There were one or two things that I think we can probably debate all evening, but no, I was very pleased, and I thank everyone for their participation.
Okay, thank you guys. Thank everybody very much. I know this is one of the few Zoom meetings that seemed too short for me, and the discussion got cut off. It's odd to say that, and I think that, I mean, we have, this is now over 2 hours into it, and we have over 75% retention rate, which is spectacular. We had 100% at 1 hour. So I think that shows the interest that is, and thanks so much. It showed the great work that the planning committee did. Thanks so much to our truly world-class faculty and support from the regulatory agencies, as well as our industry sponsors. We'll have some follow-up for everybody on this call as those involved. We'll have an authorship policy coming out, and we'll be putting this into a manuscript. Additionally, if you have colleagues who wanted to see this but could not, it will be posted on the CTC website. I guess after, you know, they go through whatever scrubbing we have to go through to stop, in case anybody says anything bad. So thanks again to everybody. I wish you all the best for a very merry, happy holiday season and a happy and healthy 2022. So with that, we'll sign off. And again, much thanks to all for a rewarding afternoon.
Thank you.
Holidays.
Great.
Thank you so
Thank
much.
you.
Thanks, everyone. Bye-bye.